The purpose of this film is to show the surgical treatment of an idiopathic adult scoliosis in a 50-year-old female patient with secondary degenerative signs and progression of the curve. As there are different options how to treat this complex problem, we intend to show that such a case can be treated by a posterior approach only, under rigorous posterior release and facet joint osteotomies, whilst attempting to omit the lowest mobile segment to protect the iliosacral joint and the hip joints. This film further presents a surgical technique which allows operating with less blood loss by sequentially exposing the spine and inserting implants. In order to support the concept of minimal blood loss, controlled hypertension and the cell saver are used. The neurological integrity during surgery is monitored by neuromonitoring during the whole surgery. Adult scoliosis can be classified in different ways. We use an etiological classification having 4 types. Type 1. Primary degenerative scoliosis, or so-called de novo scoliosis. Type 2. Secondary degenerative adult scoliosis added to an adolescent idiopathic scoliosis, or other forms of scoliosis, as well as secondary pelvis obliquity. For example, hip pathology and lumbosacral anomalies. Type 3. Adolescent idiopathic scoliosis in adult life without any relevant degenerative changes, mostly in patients aged 40 or over. Type 4. Scoliosis secondary to metabolic bone disease, as for example osteoporosis. Although the adolescent idiopathic scoliosis in adult life with secondary degenerative changes can become clinically relevant in the early 40s, it usually coincides with the menopause, as is the case with this patient. Whereas patients with secondary degenerative adult scoliosis usually complain about back pain when upright and during physical activity, they can also complain of radicular as well as pseudoradicular leg pain. This patient complained mostly of back pain when standing and sitting for a while in the same position, and of increasing limitations in physical activities due to invalidating back pain. At this point, the treatment options are either surgery or a brace to maintain the curve to a certain degree. However, the latter cannot be a satisfactory solution for an otherwise healthy and active woman. Surgery, on the other hand, offers a number of solutions and should be individualized to a high degree according to the needs of the patient and his/her health status. In this specific patient, a complete correction is not the target, and the balance in the ap and lateral view not too bad. Therefore, we should try to maintain the sagittal as well as the frontal balance by trying to stop further collapse and achieving only partial correction. There was also no need for a specific decompressive procedure, since the patient did not show any relevant radicular signs and symptoms, although in the myelo-CT there was no relevant compression. Posterior surgery alone, with a rigorous release by facet joint osteotomies and segmental mobilization with a segmental stabilization either by pedicular screws or pedicular hook screws, is possible, followed by a good posterior posterolateral fusion, either by autologous bone or a mixture of autologous and allogenic bone, or substitutes like demineralized bone matrix. These procedures yield a success rate of approximately 70%, with significant pain and function improvement. The complication rate of surgery in adult scoliosis is considered to be high. There is controversy over including the lumbosacral junction in a long fusion. Whenever possible, we try to avoid the lumbosacral junction from fusion, as in this case. This option could be chosen in cases of a sufficiently high disc L5-S1, only slight to moderate facet arthritis L5-S1, and good sagittal as well as frontal alignment. A mobile lumbosacral junction can help to reduce pain from the iliosacral joint and hips, as well as low back pain from muscular imbalance. We use the scoliosis set of the universal spine system, which has different components. USS1, the original system with lateral open screws and pedicle screw hooks. USS2, the secondary system with bilateral open screws and a lower profile. USS polyaxial, In some cases, we use polyaxial screws with the USS 1 or 2. The USS is a scoliosis system which allows correction by frontal and sagittal translation of the instrumented vertebra to the preformed rod, and mostly applied in the lumbar spine for maximal restoration of the lordosis. Sometimes bending in situ may also be necessary. This 55-year-old female patient has been treated for a considerable time as an adolescent idiopathic scoliosis without any notable progression. A progressive degeneration with increasing pain and noticeable progression of the curve to over 60 degrees, 68 degrees have been noted over the last 5 years. She describes herself as losing height in the last 3 to 5 years, indicating a gradually collapsing spine. She also complains of an increasing back pain in the last few years, mainly on the right side, where she gets the feeling that her ribs touch the pelvis. Furthermore, she has the feeling that her upper body is shifting to the right side. The back pain radiates to her right leg, sometimes down to her foot. The clinical examination shows a straight line between shoulder and pelvis. Bending forward provokes a prominent rib hunch on the right side, with a minimal lumbar bulge. There are no neurological findings. Bending on the left side is practically impossible, on the right side only with considerable pain. The predominant back pain, no neurological deficit, a tendency to collapse, and no need for full correction makes a posterior surgery with just facet joint osteotomies and rigorous segmental mobilization a viable option, with a relatively acceptable risk and satisfactory result.
This 50 years old female patient with a double major curve is positioned in prone position, and the anesthesia is preparing the patient for neuromonitoring. You see the cables going to the feet, and the positioning is checked. Now we are exposing the incision. We take a line from the occiput to the rima ani, and we identify the iliac crest, first line on the right. Now we identify the thoracolumbar transition according to the ribs, and finally we identify the end point where we want to stop with our fixation. The principle here is to make short incisions to minimize blood loss. So the first incision is at the thoracolumbar junction. These usually are 6 to 8 centimeter big incisions where we do meticulous hemostasis, all aimed to minimize blood loss. Deperiostation of the paravertebral muscles here on the left side at the thoracolumbar junction, as you can see, and we are now exposing the operating field with a retractor and with hormones. With the raspatorium, I identify the joints, respectively the lamina, and I'm looking now for the pedicle entry to put the first screw. Here we see the markers. On the left side is L1 with a pin, and on the right side thoracic 12. So at L1 you can see we are progressing now with a awl going into the vertebral body of L1 from the left side, and the exposed area is about 3 to 4 vertebrae. We change the awls. We go from a thinner to a thicker one. Here you see the lateral view with the awl in situ. Bigger awl. Here screw is already positioned, controlling the image intensifier on the left side, and now the red ring marker shows the pedicle of T12. We expose now with the first awl the pedicle of L1 on the right side after we have already put the screw in thoracic 12 on the right side. You see the progressive awl on the right side. Now the screw is positioned, and through the positioning of the screw we also have an exact localization where we are, how many vertebrae we have to go above and how many we have to go below. Preparing now in T11 on the left side, here marked with a red ring the pedicle, working with the awl to prepare the entry point. Now the screw is set, and we remove the interspinous ligaments to basically mobilize the different segments and to prepare better conditions later for the correction. We will also osteotomize all the facet joints. Now we have extended the incision cranially, again removing the muscles superiosteally on the left side. You see the arches of the thoracic spine. It's now only exposed to the left side. We're cleaning the bone from the soft tissue and meticulous hemostasis to diminish as much as possible blood loss. On the right side of the counter you see the stick of the pedicle screw in T11 on the left side. Now we prepare the interlaminar zone between the lamina of the thoracic vertebra to identify the joints, because by identifying the joints, as you can see, we are mobilizing the joint. We can osteotomize the joints and then better identify the entry point for the pedicle in the thoracic spine. So mobilizing the segment with a raspatorium and with the osteotome. Now osteotomizing the joint. This will show you the cartilage once the osteotomy has been achieved. Now we are cleaning out all the bone in this joint and we'll do the hemostasis, and finally we can identify here the entry point for the pedicle. Now the awl number 1 to mark the entry, which is basically at the base of the joint where it goes into the processus costarius, and we go now with the awl number 2, the thin awl, and are guided by the cortical resistance of the pedicle. As you can see, this goes swiftly. With this ball instrument, we palpate the pedicle canal to be sure that we have circumferential bone and we have not perforated anteriorly. Bringing in a screw at this level, it's a smaller diameter screw, 6.2 millimeters. You see these are pedicle screws from the USS2, Universal Spine System, which are both sides laterally open. The same now above, again removing the superficial part of the joint, that means the inferior joint of the vertebra above. Here we see the cartilage, introducing a pedicle hook around the pedicle We check whether it is sitting in the pedicle, and once it is sitting, we are drilling a hole for a screw which will hold the pedicle's hook in the pedicle with this central screw. The same thing at this level. So we are now at least at T8 or higher. The strength of these pedicle hook screws is almost identical with the strength of the pedicle screw which has been shown in experiments. Now we're preparing the right side. Again, all removal of soft tissue, the joint here, the cartilage underneath of the superior facet of this vertebra. Hemostasis. Here we are still putting one screw more, so this would be 10, T10, T9 is placed, T8 is placed, and T7 and 6 are hooks. So the end vertebra is at T6. Now on the right convexity in the thoracic spine of this double major, we are going to put again a pedicle hook at this level. As you can see, this is the pedicle finder, and we are securing the pedicle. Now the pedicle hook is already inserted, fixing it with the central screw in the pedicle. Now we do a claw configuration by inserting a laminar hook over the transverse process or the processus costarius of the T6 vertebra. Also this vertebra can be fixed by a screw. As you can see on the right convex side, we put less screws just on the apex to achieve through the tension banding a correction in addition to the translation we do on the concave side. Now we are preparing down, that means caudally from the primary incision, exposing now the lumbar spine. You may remember we have put the first screw in L1, and now we are mobilizing the different vertebrae, L1 against L2, L3, L4, and so on. And removing the soft tissue, identifying the joints to identify the pedicle entries. So we take at the crest, as you can see here, we take a little bit bone away at the crest of the facet joint and lateral of the transverse process, and that's where we position the pedicle screw again, palpating with this ball to be sure that the pedicle is all bone circumferentially, and placing a screw. So this seems to be in the pedicle of L3, since in the left side you see the screw stick of the pedicle screw in L1. So we have now left and right side each a screw in L3. Now we go in between L3 and L4 with a distractor to mobilize, in fact, this heavily degenerated segment L3-4. And you can always already see that in L4 on the left side we already put another screw. So the next step is the mobilization of L4, L5, and finally L5-S1, and putting pedicle screws. Here we start to instrument the first rod, and we will use a rod which only takes the lumbar spine up into the thoracolumbar junction. We pre-bend the rod in the lordosis we finally want to have, and we bring this rod on the left convex side of the lumbar spine. And by rotating the rod, we create the lordosis, and partially we will then translate the screws on this rod. But by rotating the rod in the lumbar spine, we can get a certain amount of correction. We put here an additional screw. This is a screw from the USS-1, which is just open on one side, and we will translate this screw to the rod with the persuader. Now you can see that on the left side we have a rod and in the lumbar spine, and now we have a connector, so-called domino, which will add, after the correction of the lumbar spine, the rod for the thoracic spine, which will now lie in the concavity of the thoracic right-sided curve. Here the rod is put in a way that it is imitating the kyphosis of the thoracic spine, and we will translate all the screws to this rod, as you can see here. As we have already done the correction through this two-rod principle on the left side, we can put now one piece rod for the thoracic and lumbar spine. We fix usually this rod first at the thoracolumbar junction. That means at the transition of the right convex curve into the right concave curve. What we do then is to compress the screws against each other from top down to apply tension banding, and once this is achieved, we will cross-link the two rods to increase stability cranially as well as caudally, as you can see on the right side. Finally, tightening definitely of all nuts of the screws to make sure that this is all stable, and freshening the cortex of the lamina with a gouge to prepare the fusion bed. Here you can see we are now emptying the little container with the bone, which is autologous bone, which has been taken from this patient, made smaller and mixed up with demineralized bone matrix to enhance the fusion. Finally, putting a drain and then closure in layers. The drain will be not under suction, just under hypostatic pressure. We have not done any decompression, because through the correction of the curve and realignment, it will have an indirect decompression in this patient, specifically since the patient does not have relevant leg pain, only occasionally and under load. The total blood loss in this patient was less than 500 milliliter, which is pretty little for a big adult double major curve. The purpose was not to completely correct, but to balance the spine, specifically in the frontal plane as well as in the sagittal plane, and to basically stop the progression of the curve and the instability, which can be considered as a global instability, as the major pain generator in this patient. The postoperative treatment is soft brace for at least 8 to 12 weeks as a protection. Patient will be immobilized immediately after the surgery. That means the first day after the surgery. Isometric exercises, which the patient learned before the surgery, will be done postoperatively with consequence, and about 3 weeks after the surgery, when the patient has clean wound and well healed, the patient will go in a walking bath where the water has the height of her breast, and she will do walking exercises in the water, because the water will support her. This will unload the spine and relax the muscles. This is, besides the isometric exercise, is the best postoperative treatment, and there is no need for any active physiotherapy.
No complications. First follow-up control. Very satisfactory result. Back pain gone. Sometimes lumbosacral pain with irradiation into both thighs, ventral and dorsal. However, no radicular pain.